What is this ocean that we call primary care? Welcome back to Health Policy Off Script as we jump in with both feet. Today's discussion will be with our three hosts, Ivy Bourgeault, Stephen Lewis, and Dale McMurchy. Let's start simple, or maybe not so simple. Let's keep this one very short. What is primary care?
Thanks, Matt. Yeah, so the primary care system for me is the way that everybody enters the system. It's a bit of gatekeeping, but it really is that first foundational step of the system. And as a foundation, it should be very strong in order for all of the rest of the parts of the system to be based upon it.
I think that's what it is. And I think historically, for all sorts of reasons, it's been a doctor and lately, sometimes a nurse practitioner. But it's been a fairly narrow channel to a very big set of needs. And I think what's on the table is exactly your question. What is it? It's a portal right now.
So it is a portal, and it's the first contact. But critically, it includes prevention, acute care, and chronic care, and end-of-life care for all ages. And I think the critical part is that although many services in primary care in Canada don't provide that gambit, it is really important that it addresses the social determinants of health along with the most acute and chronic conditions.
Well, in some cases, care can be quite comprehensive. There are some really leading practices out there, but I think that the policy needs to be stronger to spread and scale.
Yeah, I would say our issue is that we conceive of primary care as part of a vertical system. So it looks after some things, but then when things get quote unquote really serious, we punt them to specialists. Ideally, for me, primary care is something from which I should never have to depart until I'm very old and very ill.
I would agree that primary care needs to have a greater interaction and greater integration with certain specialties and also have them actually as part of their team. But primary care is evolving in Canada, and we need to actually bring the rest of the system along to operate in a way that is actually providing quality care, but very high functioning administrative care.
I think it does come down to how do we define comprehensive? That is a principle in the Canada Health Act. It's one of the C's of the 4 C's of primary care. And defining that has to go beyond just medical providers.
And certainly there are teams that provide mental health and musculoskeletal care. But by and large, because it's not covered under provincial systems, often those are excluded. And, it makes no financial sense. And then ironically, those teams that do provide those services are battling for the dollars to support mental health and addiction care.
So let's turn a little bit to the policy implications that arise from this comprehensiveness discussion. So we've talked about the Canada Health Act and what it requires us to do. But one of the artifacts of that is that we have this quite large, quite fragmented private insurance system and employee benefit structure, where you have all these companies providing the physio, the mental health care, depending on what it is. And ironically, many of the beneficiaries are working in the public sector. They're government workers, they're civil servants, and so on. So you have this two-part system, one of which is employer and employee funded add-on services, which tack on the comprehensiveness to some extent to what we get in the fully public system. If we were starting over, I suspect we would question whether that was the right thing to do, given the needs of the population. That insurance structure, which of course governments kind of appreciate to a certain extent, because it means that there's less pressure on adding money to the primary care sector by making it more comprehensive, but it's also a problem. And it really comes down to what your ambition is for primary care.
Yeah, and I think that we've not done a very good job of calculating opportunity costs, downstream costs, and how investments upstream can be a better return on our dollars invested.
But there is evidence. There is evidence. Just to interject quickly, there is evidence that providing care and comprehensive care to the most in need is cost effective.
So
And
why is this
over and
not
over
moving
again.
people?
Well, I wish I knew, Stephen.
So let me ask the two of you. When I hear us talk about this, you should get the care that's going to either maintain or restore your health as quickly as possible and full functioning and so on. Who does that now? Workers' compensation boards. We will give you very quick, very intensive services to get you back to work. It seems to me that system does take a more holistic view of this. They don't care what the service is that you need. If you need it, you need it, and we're going to get it quickly.
Quality. We talk about it, but in reality, we really aren't measuring apart from, drips and drabs here and there. And where we are, even in the reporting of those quality indices, they sort of fall into a black hole often, like who's reporting back, who's holding people's feet to the fire in terms of the care that people are getting and the outcomes.
During the opening, we discussed a number of things to get started. Again, sticking with the water motif, we just dipped in our toes. Before we get a little deeper, one more question. I think everything that we've talked about is fair to discuss when we talk about Edmonton, Vancouver, Halifax, Toronto, Montreal. But is this conversation the same if we're talking about Iqaluit, Moose Jaw, rural Labrador?
Well, I spent most of my life in Saskatchewan, which is still a pretty rural province. And it's not just rural, but the towns are small. So you always are going to have a critical mass problem. The more local it is, the less likely it's to be comprehensive. Almost no Canadian trained doctors will accept that kind of assignment. Ever have.
It depends. It depends. So speaking as a person who grew up in one of those areas on a farm outside of a town that boasted the population 303, Marsland, Saskatchewan. So shout out to them. And also just rural areas in Alberta. There's rural, there's more remote, and there's north. And so those are distinctly different circumstances. And we often sort of think of urban and rural remote. And they are different. It's whether you're driving in or you're flying in. I think that we can do a better job at developing the workforce that is already in those communities, pathways to different health occupations for youth who are in rural and remote locations and northern locations. And that would be very consistent, with the calls to action for the Truth and Reconciliation Commission 23 to develop more of an Indigenous health workforce. When you look at Nunavut, where 80-85% of the population are Inuit and less than 10% of the population of the health workers are Inuit. So there's a huge opportunity.
Well, sure, but the reality is, in my view, you cannot have anything like a comprehensive primary care center for fewer than 3,000 people. It's just not possible. But there is a potential solution in terms of virtual care telehealth. We can do a lot more now. I think this is actually a great boon to the prospects for rural and remote care.
But I think there are some critical factors to keep in mind when we talk about the care that's provided in rural areas. Yes, driving 25, 50 kilometers to get services may be the way of life, and that's problematic. There is a level of patient-centered care, a coordination of care that may be unique to those areas. Everybody knows each other.
Okay. That's a question I think that we could go on forever about. It's an episode on its own, and there are a number of people that we could invite as guests for future discussions about rural and remote care. So let's get into it. Simple question. Is anybody doing it right or even close to doing it right?
Okay, so I think probably we need to address this on a service level basis and then at the system level. There are some rock stars out there in terms of service delivery. Some of them are doing an absolute amazing job. And there are a number of things around comprehensiveness and quality and well-managed organizations and a whole number of things. And there are primary care services out there that are hitting the mark on all of those, or, let's say 80% even, and providing excellent patient care, a good environment, quality care, or they're paying attention to quality anyway. And they provide interprofessional team-based care where the team works effectively together. The problem is that that's not everybody.
So how would we get there from a systems perspective? Because yes, I think that primary care, when it works really well, they understand their community. How do we get the system for that to be the norm, and that the system is supporting that as a norm?
We don't even have a primary care strategy, not a national one, not many provincial ones. Like, what are we trying to achieve? We haven't even defined that. So we're missing like the foundation.
You can't have one profession that is separate and unequal from all the others if you're going to have a true team. That's how we set up family medicine in this country, primary care physicians. They bargain separately. Most are paid in a different way. It is fragmented by design. And the big bargain of Medicare was that physicians will remain arm's length from the system. They're not fully in like they are in the NHS and like they are in some high-performing systems in the United States, like Kaiser Permanente.
Is that like some assumption, or is that like written in stone?
Well, it shouldn't be written in stone, but it's part of the collective agreement. And if you're going to have a separate collective agreement with all of these professions and then expect them to work as a team when you pay them differently, when there are disincentives to working out the division of labor more sensibly with people in your team, those are real barriers. You've got to bring physicians fully in. This is roughly what you get paid per person. Of course, you adjust it for their age, gender, complexity to a certain extent. So this is your money. This is your pot of money. It's enough to fund a comprehensive range of services, which you would have to figure out. Go to town and do it, and you have an incentive to find all sorts of efficiencies.
There's got to be more to it.
Well, there is more to it. But I mean, again, you say, look, do we expect these primary care to be a bunch of autonomous entrepreneurs who get their own office space and buy their own equipment and contract to the public system and run it like a business that way? Or is this a public utility? And say, look, this is the core public service in the country. Would organize the system around complex, frail, elderly people. And I think if you succeeded there, you would succeed almost universally. Most people, especially most middle-class people in this country, are pretty healthy, and they hardly use any health care. They don't feel an urgent need to demand a system like that. And that's why, in its own dysfunctional way, it works perfectly well. The system works perfectly well for people like me, touch wood. I'm a healthy old guy, and I never see my physician. And that's the norm for most people in the country. Investing in a system that looks after people and does a great job where it fails now with more complex needs and with people with more comprehensive needs, that's why people aren't marching in the streets for what we've been talking about.
Yes, we want to make sure that a primary care system is meeting the needs of complex folks that have multiple chronic conditions. Absolutely, that's a particularly important segment of the population. There are other segments. I want us also just to kind of come back to, so just to build on your point, Dale, about strategy. Some provinces do have strategies, and some of those strategies are like Hail Mary. It's like, we would love this, but they haven't done the work in terms of how that's actually going to get implemented.
But I mean, I disagree when it comes to just focusing on the most complex patients, because the whole idea of primary care is to get there sooner, to actually stop people from becoming complex patients. And we know that, really important interventions are early childhood development and monitoring children as they evolve. Mental health in children, we know, is on the rise. The doors need to be open for the entire population. Those are the opportunities or missed opportunities if people aren't walking through the door and they don't have access. You are a frail elderly person.
Stephen, what's the role of the feds or the provinces in all of this?
The feds have 50 some billion dollars worth of leverage here in transfer payments to the provinces. I think it would be in the interest of the country for Ottawa to invest in doing some of this with bilateral agreements with willing provinces that want to go a different direction. I mean, I think I give Ontario pretty high marks for trying more stuff than most other provinces. I think we're agreeing, but maybe we're not. The idea of a comprehensive approach, which has more disciplines, more capabilities, and is more accessible, I think that's what we all want. We all agree that it fails the people who need these services the most. And Dale and I can argue on another episode about whether or not we should continue to medicalize every kid from the age of 2. But basically, the biggest problem we have, simply from a policy point of view, I continue to believe, is you have to bring physicians in so they actually are incentivized to become part of a team that would make their capabilities go farther and would use everybody else. The division of labor, the unused talent and knowledge in the system is a scandal. And I think the feds can influence this, Matt, but I don't think they can legislate it.
But I would be focusing on the universality and access and mandate an open door for everyone in our universal healthcare system, for everyone to walk through for primary care. In the short term, it would be bumpy, and you'd have to have multimodal provision of care. You'd have to extend hours of services. But if they start to coordinate and share their workforce, share their programs, maybe improve the administration, have kind of back office coordination and start to save money that way, and work together perhaps to provide some after hours services, so that there's an open door for everyone.
But Dale, before Ivy gives us the real answer, Quebec tried that. They just tried it. They just said, we're mandating it and there's no option.
No, that's
We're going to
different.
assign patients. Well, what's different? How are you going to mandate it? Like, tell which door that has to be open to patients that isn't now. I mean, that's really hard.
If you have to serve patients in your geographic area, and that your services, you may have to coordinate with other services in the area to provide a walk-in, you're going to have to collaborate and figure out how it is that you serve your population.
And what if you don't? What happens? What's
That's
the remedy?
The accountability comes in. That's the second tight. So you're tight on how much money do we have to spend on this? The federal government will provide that to provinces and territories, but we also need to recognize that municipalities are really important, civil society organizations. So this is an all hands on deck governance system that we need to have. Different practitioners, different approaches, really loose on that, but you have to meet at the other end very tight on what are the requirements. And so yes, everybody is covered, everybody should have access. So this is beyond just attachment, but that people truly have access to, the 4C quality of what is primary care: comprehensive, continuity, first contact, coordination. So you need to have, those need to be different performance metrics, and you need to report those. We don't have that. So if that was integrated into a primary care strategy, whether it's a provincial, territorial, or federal strategy, great. But you have to give people some opportunity to innovate, but it needs to be really tight. You need to meet these targets, and this is how much money you have. And here's the population that you need to serve in the best way possible.
Is anyone accountable?
When the system doesn't deliver, what happens? Because we know what happens now. They say, you can't hold us accountable for enrolling the 20% of adults who don't have the door open to them because you don't give us enough money. And then governments say, yeah, you're right, we're giving you more money and we're going to pay you more money, which is frankly absurd. there's a lot of accountability talk, but I think we would all agree there really isn't any, not for quality or not for access, really.
No, so that means that the inputs are not tight, right? I mean, if you get more money because, I mean, there are some things that you can make the case for some exceptions, for sure. But that means you're not tight on the inputs if you're providing more money. And then that means you're not tight on the outputs because you're not achieving performance measurements, right? I mean, if we, as employees, don't do well, we get put on a performance improvement plan, right? So how do you then partner between
Yes.
those who are excelling and those who are struggling? And how do you, create some synergies between that? That is either not happening or happening on an ad hoc basis because all of the energy is put into we need to change the inputs, we need more money. So we're not actually accountable for the outputs. So neither of those things are tight. What ends up getting tight in the middle is how you should go about doing that. Like as if we have that knowledge to micromanage people in the system, practitioners in the system to meet their community needs. We have to give them tools, to do that.
Right. And to follow on from that, I think, Stephen, you're like, how actually are you going to implement this? And you're right, the tools need to be in place or the infrastructure within communities to do so, because it's going to entail discrete primary care practices working together to improve access. Rather than say, one practice and that practice, you need to increase your patient load by 20%, you have to have greater coordination and discussions and collaboration among primary care services to look for things like economies of scale, where your services overlap, how you can improve the effectiveness and efficiency of the services you provide, and then through that collaboration, potentially open up more doors for patients locally.
So I think both of you have actually identified both the problem and the solution. Primary care, like the rest of the system, you have to manage it like you manage any complex human enterprise. And there is no such thing as autonomy without accountability. Well, this is a cultural change of enormous proportions, particularly for medicine. I mean, a nurse in a hospital wouldn't find this strange, but physicians do, and they resist it. I mean, let's face it, this is a really important element here that, yes, clinical care is measured and managed, and when there are problems, there are defined strategies for improvement, just like every other person who works in every other enterprise that is successful. Primary care is no longer a cottage industry where you get thousands of people making autonomous decisions about where they practice, how they practice, whom they serve. Well, this is common sense in one level. It requires digging out from a whole lot of history and a whole lot of tradition. So back to Matt's question. This is why, Matt, you can't legislate cultural change.
Right. But let's be clear, it's not just physicians.
No, but
I've worked with teams that were trying to get to integrate
Well, yes.
work together.
There are lots of other practitioners in communities that are cottage industry, right?
I
So
agree.
psychologists doing things privately, physiotherapists doing things privately. So there's lots of health practitioners that can be brought into primary care and for them to be thinking that they can contribute to a primary care system. Some of them are leading, but some of them aren't, and need to be brought into this primary care fold. So yes, it includes physicians, but it includes many others as well.
It does. And I mean, to make it really concrete, what do I want? Since I have, I'm 74, so I am on the verge of this complex, frail, elderly person that I keep talking about. If I can't go to one place to get my eyes attended to, my ears attended to, my range of motion attended to, probably the last person I'm going to need is a physician. I'm going to need other people before that. Now, this is basically, I'm all over the place with different providers, even now with my relatively modest needs. So when you think about it, take a step back. This is craziness. And that should be our North Star. Just like it would be crazy if I have to go to one bank to take cash out, and I have to go to another to make a deposit, and I have to go to another to talk about a loan. It's, that would be insane. So,
right, but the system is built for this competition, and
that's my point.
It promotes turfdom, if that's such a word. And so even when we talk to primary care organizations that are teams, hey, let's all work together. You're, kind of within a catchment area. There's 4 of you. Why can't we collaborate? Nope, we're funded separately. We're breaking the rules. We're not allowed to, move funds outside our organization. And that's within primary care, let alone all the siloed funding for mental
Right.
health and specialists and otherwise.
There's
So
siloed funding, there's siloed regulation. Nobody's ever regulated to work as a team. They're regulated to work by individual
Correct.
practitioner, as if that's the way anybody's practicing now. They are siloed in terms of their education. Nobody has in their educational components what everybody else does. It's all a lay level of knowledge about what all other practitioners do, or ad hoc or by experience. And so how can you build trust? Everyone says, we should have primary care teams. They should know how to practice together like a hockey team. Well, we don't even have people knowing what the goalie, what the center forward, what the defenseman does. Those are all of the silos that we have to break from a structural perspective.
right. And then the thing we overlook is that, in fact, we actually need high functioning organizations with strong administrative and clinical leadership. And we need change management, we need a change in culture, and we need people who are actually highly skilled executive directors and CEOs to run these organizations, because we're talking about very sophisticated organizations now that have to manage diminishing budgets, quality, a health workforce, patients. There is a level of complexity in managing a primary care team that is often overlooked and underfunded.
And that's a different skill set than the clinical skill sets that you need to deliver primary care. It's an additional skill set that you need.
My hunch is if you took half a dozen professions of recent graduates who've been practicing for 2 or 3 years and put them in a room for a week and say, design a primary care system that is going to meet the needs of, let's take 4 prototype kinds of patients. I will expand my horizons.
They would need a very good moderator.
Yeah, but they would do it. I think they would do it. And they would, whatever they came up with would be a damn sight better than most of what we have now. And they would talk about, here's how you would fund it. Here's how we would want to do the pay. Here's what we'd figure out the division of labor. Here's what we would ask our regulators to get out of the way on, or to add some depth to, as Ivy was saying. I think they would do it.
I think it's been done, but none of the outcomes of those things has ever had teeth.
Well,
They've
teeth
been
is
fairly
another matter.
scaled, right? Again, because that's the part in the middle that you want loose. You want bright, educated, hardworking people to figure it out. And it might look very different in different communities, but you still have a requirement to achieve certain outcomes, and you have a certain amount of money, tight, loose, tight. So that's very important to create a system, and all of the other supports around it in terms of funding, regulation, educational supports, and tools for those teams to be able to deliver the services to their communities. And go to town with how you want to innovate with that, for sure.
But the trouble is, some of that is happening, and it's still a little messy and a little ugly. So there's still those silos, and there's still that turf, and it's very hard to crack that nut. And so I'm not sure if exactly how you'd address that, but some of the things that are happening on the local level, there needs to be someone who is a recognized leader and who can be the decision maker and bring things to fruition, because they've got to work through that culture change and the change management and working with diverse perspectives and people who are actually feeling threatened. And I don't want it to sound like all of those community-based initiatives that bring together various interests and services to work together. Some of them are doing it amazingly well. And there are lots of examples where community groups have come together from different types of services to work together to improve care in their area. But there's still not enough of an infrastructure that actually helps make that happen in a real way and helps those communities that are having trouble getting people to work together, collaborate, let their defenses down.
Innovative practices work around. What are the workarounds that they have? When you understand what those innovative practices are working around, change what that is that they have to work around in order to meet the initiative. So it isn't just about tight, loose, tight. It's about, in that loose part, really trying to kind of figure out what are the structural, whether that's funding or regulation or practice location, et cetera, all of those different permutations, health information systems, that don't talk to each other, for example, what are the workarounds
Budget
that
line
can
items.
change those?
Someone somewhere has done all this work 15 times, but it just doesn't stick, and it just doesn't spread. So that's what we need to really nail down, right? Like what are the barriers to doing what everybody seems to think would be pretty sensible?
Yeah. Okay. You've all brought up a number of issues, sure, some differing opinions, but where are the roadblocks in all of this?
What are the barriers, Matt? One of them is this. Even people who will pretend to agree will say, well, then you have to spend a lot more money. Because the scarcity narrative, that our system is, to the bone and blah, 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 which I, for one, think is nonsense. Even the public agrees with that, which is shocking. I mean, it's terrible, actually. The public, there was an Ipsos poll from late 2025 that said 80% of Canadians say we're okay if governments spend more money as long as it's targeted to healthcare. In what other industry do the people working in it get to decide what they're interested in accomplishing and being accountable for? Why doesn't the system change? That's why the system doesn't change, because a bunch of people don't want to, and they will pay lip service to all this stuff, but they don't mean it.
Then how do you get them to mean it? Like,
by policy. You say, look, this is what's happening. You want to work in this system. Here's the information system that we use. Here are the quality indicators. You can co-design them, but there's going to be some. And you're not going to make them up all by yourself, because other people actually have something to say about this, like the patients. Like, it's just common sense. But this is on the ground stuff, right? This is the Matt.
But you need the carrot and the stick. Like, you definitely need the policy, but you need to figure out the carrot. We haven't figured out the carrot.
Well, the only carrot the government uses is, we'll pay you more money.
No, there's no stick that one can do, right? I mean, here are some tools to use that will enable you to meet the needs of your community better. But if we don't spread and scale those tools that different, innovative practices are using, then they're asked to do something. They're asked to build a shed without a hammer and a nail.
Yeah,
right?
and that's what those provincial quality improvement agencies are supposed to be doing.
But they do it the way, Dale, you and I would think they should do it, and that's why they get nowhere. Because, honest to God, I think the solution is call their bluff once, and you'll be fine. As if a doctor says to us, "I'm not doing that, or I'll leave," I would say, "Can you leave tomorrow? Like, just go. We'll manage." Seriously, they got no place to go. They're always bullshitting. And they say, we're all going to leave the province. Yeah, we're going to take your kids out of school and your wife out of her job, or your husband out of your job, because I'm pissed with you.
The doctor could be a woman.
Okay, sorry, gotta cut us off there. We're out of time. No way this conversation is even close to finished, but it is for the moment. I hope you enjoyed this episode of Health Policy Off Script and are looking forward to more. Thank you for joining.